Today I'd like to have some acknowledgments first, because I pirated most of these slides from 3 people. Desiree Morgan is a radiologist that is a faculty expert in radiologic evaluation of pancreatic cysts, and I think that's where it starts, and we'll see why in just a minute. But it starts with the x-ray. Sushant Reddy is one of our surgical oncology faculty, put together an outstanding grand rounds on pancreatic cysts in 2012, and I grabbed some of his slides because they were much better than the slides that I would have put together. And then lastly, Elliot Newman is my 911 lifeline for intraoperative problems. Everybody has to have one. But he also had he's part of a working group on, international group on pancreatic cysts, so we got some guidelines from him. Just like to thank them. So why are pancreatic cysts being identified more? Because virtually every American that goes to the doctor gets a CAT scan if you have abdominal pain. You cannot burp and not get a CAT scan. And so even if you don't have abdominal pain, sometimes you get a CAT scan. It's essentially an H and CT when you roll through the emergency room, and if you go to the doctor with pain, that's what you're going to get. About 3% of patients are found to have a pancreatic cyst on CT scan, estimated to be a pretty big number. And then if you roll in ultrasound, MRI, and you add all these things together, you have this enormous number of incidentally found, or maybe not incidentally found in the symptomatic patients on CT scan. So it's estimated you have about 500,000 new pancreatic cysts identified every year. That's a lot of cysts to evaluate. So what's the problem? Because having all those cysts is not the issue. I mean, it's part of what we do, but the problem is it's concerning for the patient and the family, especially if they have an internet connection. Because you tell someone they have something wrong with their pancreas and they get on the internet, it is fear. I mean, their adrenals become little raisins and their anus becomes a scar because they're so worried at that point that they cannot, they got to get to the doctor because they think they have pancreatic cancer anytime they have a pancreatic cyst. Secondly, it's challenging for the radiologist. Now, we pick on radiologists because they hedge from time to time. That's part of the basis on which they live. But the reality is they have to make a decision versus an overcall or a realistic risk assessment, recognizing that there's something in the pancreas which can be a problem. And then lastly, it's challenging for the surgeon because, like in every oncologic problem, we're balancing 3 things. You're balancing out the biology of the lesion that you're trying to predict without having pathologic evaluation most of the time. You are looking at the comorbidities of the patient. And the people that get CT scans are probably a little bit on the older side, so you have the comorbidities. And then you have to look at the technical aspects of the operation. What is the placement of the cyst? What is the relationship to some high-priced real estate that lives nearby? And so when you put this together, you say, here's the problem. These are the factors. It's not just the cyst. It's all the things that go along with it that make it an issue. And this is where the judgment comes in. Hopefully Watson, the IBM Watson computer, won't replace us being able to balance these 3 things out yet. They're going to try, but hopefully not yet. And so today what we're going to talk about, there are a number of other smaller cysts. We're going to focus, it's a 15-minute talk, we're going to focus on the neoplastic cysts. We're going to go from the serous to mucinous, and in 3 categories we're going to just look at serous, the characteristics, the imaging, and then some recommendations for management on serous cystadenoma, intraductal papillary mucinous neoplasms, and mucinous cystic neoplasms. Those are the 3 things we're going to talk about today. And in general, going from more benign towards malignant. So first, a serous cystadenoma, generally speaking, 1 to 5 times women over men. They tend to be in the older population. The biology is a numeral number of small cysts, 1 to 20 millimeters. There's generally a central scar, or characteristically a central scar with some calcifications, produces glycogen, tends to be in the head more than the tail, almost virtually benign. So when you look at that on CT scan, again, a CT scan just shows the cross-sectional imaging. For reference, this is the aorta, this is the vena cava, this is the superior mesenteric artery, the superior mesenteric vein, this is the head of the pancreas, and what you see is a varying density of central calcifications and then cysts on the side. Here's another view imaging giving the more classic serous cystadenoma, which shows again the central calcifications, the surrounding cyst here and here. This is an intraoperative view of the gross picture prior to resection, seeing the serous cystadenoma. Here's the head of the pancreas, and you can see the correlate between the cut surface of the serous cystadenoma and what it would look like radiologically. These are essentially benign lesions. Most of the time, we're going to leave it alone. So from a management perspective, it's primarily observation. You resect for changes in size, the presence of symptoms in the appropriate patient that has an appropriate comorbidity profile, and it's technically feasible. So intraductal papillary mucinous neoplasm. Most of the controversy around pancreatic cysts happen around IPMNs. That's where the decision-making comes in. It's where your risk of cancer goes up, can be significantly, and this is where most of the angst and the hedging goes on. So the synonyms that you see would be a ductectatic lesion, an intraductal papillary adenocarcinoma, which is really high-grade dysplasia, or a pancreatic villus adenoma. It is ductal origin, and it produces mucin in the cyst, and it may involve the main duct or the branch duct, and the risk of malignancy generally centers around the differentiation between main duct and branch duct cysts. Again, maybe malignant or pre-malignant. They generally grow slowly, and in fact, the adenocarcinoma associated with IPMN generally has a better prognosis than your garden variety pancreatic ductal adenocarcinoma. And the side branch lesions are often benign. So this is an MRI, and just to orient, this is the gallbladder here. This is the bile duct. This is the pancreatic duct. And what you see here is the branch duct that goes out to an IPMN cyst. Arrows for emphasis. That was from the radiologist. This is obviously a slide from Desiree. And so no, actually, if it was a radiologist slide, there'd be 10 other pictures up there. And so this demonstrates a small cyst in between the bile duct and the pancreatic duct. So this is a presumed side branch IPMN. When you look at the risk of malignancy in IPMN of the pancreas, the main duct, it's diffuse or segmental dilation of the main pancreatic duct, defined as greater than 5 millimeters without an associated cystic lesion. And this picture here gives probably the best, this CT scan gives the best definition. And what you see, here's the superior mesenteric to portal vein. And what this demonstrates is the pancreas right here, you can see cystic and ratty dilatation of the main pancreatic duct all along the pancreas. This is a segmental involvement of the main pancreatic duct with cystic dilatation. Again, the same orientation. This is coronal and this is axial. You can see the superior mesenteric artery, portal vein, pancreas, main pancreatic duct is normal here, segmental dilatation of the pancreatic duct in the body and tail of the pancreas. This is a combined lesion, and the combined and the main duct carry the same risk of malignancy. You have a cystic lesion with the main pancreatic duct dilated, best illustrated here, where you see a cystic area towards the head of the pancreas, and then the main pancreatic duct with some ratty dilatation throughout. This is a cut picture which demonstrates a side branch IPMN here, and to give credit to Scott Young, our pathology associate that does these masterful cuts and pictures. What this demonstrates is the bile duct here. You can see the cystic duct takeoff. You can see the pancreatic duct is bivalved, and what it demonstrates is this large, relatively large side branch IPMN with some excretion or some papillary features in the central portion. This cyst turned out to be benign, but these are the ones that are at higher risk because of their size. So in general, if you look at the International Association Sendai criteria, resection is indicated for all main duct and combined type IPMN. That's where the highest risk of malignancy. I think the biggest challenge for the surgeon is figuring out where to stop, because a total pancreatectomy is not a trivial operation for the patient or the doctor. You turn these people into brittle diabetics, and for a risk of malignancy, oftentimes there is a mass or a larger cyst associated in a combined fashion, and the problem again is where to stop. I tend to shy away from a total pancreatectomy because of the comorbidities, often the comorbidities of the patient already, and the future morbidity that you're inducing in the patient. For branch duct IPMN, generally speaking, size, the presence of mural nodules, the presence of symptoms, and or the presence of mucin or an elevated CEA are the factors that contribute to the risk of malignancy. When you look at the risk of malignancy, this was 8 studies of resected IPMN with 475 patients. The main duct or the combined duct IPMN, the risk of cancer, 20 to 50%, and malignancy, that would be including a high-grade dysplasia in the 60 to 90. I think the important thing to recognize in the IPMNs, on the branch duct IPMNs, much lower risk of cancer. There can be high-grade dysplasia. Size being one of the most important things, and we'll just have a short algorithm on that at the end, looking at very low risk of cancer in the small cysts. Mucinous cystic neoplasm is the other one that we'll see commonly. Less common than the IPMN, but it is one that we see. And this is it, the ratio of women to men is much higher, 9-to-1 in women, relatively younger, uni or multilocular cysts with thick septations. You'll see often peripheral calcifications. They're much more often in the tail or body, and they can have premalignant or malignant characteristics to it. This is a picture showing incidentally found in a 34-year-old nurse, a 46-year-old, a 44-year-old, and all of these were incidentally found. You can see these central, very relatively large lesions without the septations or the internal traffic that you would see like with a serous cystadenoma. This is a cut specimen of a patient with a mucinous cystic neoplasm, and it just correlates to what we saw on CT scan. A relatively thick rind, central either necrosis or mucin production, and in the body and tail of the pancreas, this being the spleen. So the management is primarily resection. Appropriate comorbidity profile, again, technically feasible. Generally speaking, because of the size that many of these present with, often don't get a biopsy to prove that. Usually by imaging criteria, you can make that diagnosis. So what's your algorithm? A safe algorithm? Oh, one more thing to include in the algorithm, because the question comes up, how can EUS FNA help? Well, it's generally indicated when the imaging is indeterminate. So we're trying to make a decision about the internal echoes and the septations and the presence or absence of mucin. Again, it'll differentiate mucus versus non-mucin and look at serous. You can look at CEA. For asymptomatic cysts, because the ones with symptoms are generally going to the OR, so you probably don't need it with symptoms. It often comes to us already with an EUS, since every hospital, every region of the state now has people that does it. So therefore, most of the time they come with it. Again, you can use amylase and CEA to differentiate. And there is an opportunity for molecular analysis, and there's research looking into the genetic profile. So quickly, less than 2 centimeters, single follow-up with a MR. And again, this is a radiologist writing this. I like CT, thin cut pancreas protocol. CT scan does just as well. If it's stable, no further follow-up. If it grows, then you need to follow it longer. You can decrease the interval if younger, omit if in an advanced age patient, and again, the radiologists like the T2 weighted MRI. So 2 to 3, this is your intermediate zone, still relatively small, relatively low risk of cancer, uncharacterized. You're going to follow it. If you think it's a branch duct, it's every 6 months for 2 years in the physically fit patient, and then a serous cystadenoma every 2 years, looking for growth or symptoms. And then lastly, greater than 3 centimeters, serous cystadenoma, you consider resection when it's enlarging or symptomatic. If it's uncharacterized cystic mass, aspiration with EUS, and then looking at the criteria of comorbidities, mucin, change in size, things like that for your branch duct IPMN. So, I included this mostly for, I know I didn't have my slides out here, but anybody who needs them can have them. This is more for the high-risk criteria. If you are generally greater than 3 centimeters, if you present with any of these things, you need an operation. Your branch duct, your main duct, your enhancing solid component, and the obstructive jaundice. The worrisome features, and mostly what you'll see in the branch duct IPMNs, is the larger cyst, one with mural nodules, a dilated main pancreatic duct, a change in caliber distal to the cyst, or peripheral calcifications, EUS to confirm the worrisome features, appropriate OR candidate, off to operation. So, in conclusion, pancreatic cystic lesions are increasingly encountered because of the way we practice medicine. Most are asymptomatic, less than 3 centimeters, often unilocular, and they're not invasive cancers. Imaging follow-up is generally a reasonable course of action, and it's the balance, again, or utilization of EUS and resection are appropriate in the properly selected patient after assessment of risk factors. And again, it is the absolute balance between your comorbidities, the technical aspects of the operation, and then the perceived biologic risk. That's what you have to put together.